Hey, podcast listeners, Fawaz Al-Mufti here from Westchester Medical Center, New York Medical College, and this is another episode of the Neurocritical Care Podcast. Thank you for joining us on this special edition of the Neurocritical Care Podcast on COVID-19. As a novel coronavirus impacts lives around the world, COVID-19 viral illness has swept into at least 114 countries and approximately affected almost 400,000 patients globally and almost 20,000 deaths as of the time of recording of this podcast. And as of last week, it's officially been declared a pandemic by the WHO. New York has witnessed an exponential increase in cases over the past week, with the number of cases almost doubling every 2.5 to 3 days. In what is clearly a very rapidly evolving situation, in this episode we will try to separate the signal from noise by tackling issues pertinent to any intensivist. I'm very glad to be joined today by Dr. Ann Lipke, pulmonary critical care attending and director of the medical ICU at Swedish Medical Center in Seattle. I'm also glad to be joined today by my former co-fellows and now critical care trailblazers, Neha Dengaich, who's an assistant professor of neurology and neurosurgery and director of neuroemergency management and transfers for the Mount Sinai Health System in New York City, and Chris Zammit, an emergency medicine physician and medical director of stroke and neurosciences ICU and acute neurologic emergencies in TriHealth in Cincinnati. And Neha and Chris, welcome. Thank you very much for joining us today.
Thank you for having us.
Before we start to record, we were discussing offline who the most vulnerable people are, and often any virus or contagious illness, the most vulnerable people are the very young and the very old. That's not exactly the case here, is it, Anne?
No, we, as you probably know, had our outbreak really identified initially at a nursing facility, which is an issue for two reasons. One, these patients are particularly vulnerable to early and severe disease. And, of course, the means by which we care for many of our older people in our population are population dense, which of course seems to be a problem for spread. So our first outbreak was at a nursing facility, and we've actually seen that repeated several times over the city. Thankfully, our children have not been affected in a serious way, and that's, I think, at least decreasing some of my level of anxiety about this as a mother.
Yeah, wow. For the audience, just to set the stage here, so when somebody has symptoms of consistent with COVID-19 or is concerned about having contracted COVID-19, do they have to go to the hospital or can they be treated at home? And at what point do you recommend that patients need to go to the hospital, and what would happen to them then?
Well, I actually have an outpatient pulmonology practice as well, so full of older population for the most part and pretty vulnerable at baseline. Because of the sort of overwhelming number of cases, and as you know, most of these cases are relatively mild disease, we are trying to keep many of our patients out of the hospital if at all possible. So we've set up telehealth visits and a pretty robust call-in system, but there is telehealth monitoring available for patients that have fever and mild symptoms. If they start developing hypoxemia, which we can actually measure remotely, or severe dyspnea, then we have them come into the hospital, of course. And the patients that are more hypoxic than what we can manage through telehealth, so we can get them small amounts of oxygen at home, those patients are brought into the hospital for management. We've actually been seeing, unfortunately, and this is, I guess, one of the flaws in the telehealth system, some of the patients, when they start to develop hypoxemia, deteriorate very quickly. So, for example, and I'm sure you guys have started to see this or are seeing this in the same time that I am, that many patients we will see arrive on 2 liters, and within a couple of hours they're on 6 liters and then a non-rebreather and then intubated and then prone and paralyzed within the course of 6 to 12 hours.
Wow. So let's focus for a second on the containment phase of this disease. Chris, who's being tested, and what is the turnaround time for the lab test? And are your colleagues being quarantined until the results come out if someone was exposed? And how does symptomatology factor in?
Yeah, this has actually been a huge moving target for us. And then, actually, I'm curious on what you guys are doing in Seattle. So most of our providers are following the state-based recommendations for testing. Our turnaround time for testing has been quite long, frankly. For non-hospitalized patients, we are one of the facilities where we're using one of the central labs, which I think most people know by this point. Some of those central labs were pretty overwhelmed with the initial tests that were presenting last week. Tests that were sent about approximately 10 days ago to the Utah lab, ARUP, were ultimately sent to different labs like Quest and LabCorp because the ARUP was overwhelmed, and of course ARUP is also in Salt Lake City, and as luck would have it, they of course were affected by an earthquake there. which further complicated some of their operations. So some of our initial turnaround times have been as long as 9 or 10 days for testing. It's getting a little better. It's closer to 6 or 7. In the state of Ohio, we've been very fortunate that the state does have a mechanism which we can send some of the hospitalized patients. So if somebody is significantly ill, meaning if they're hypoxemic, requiring supplemental oxygen, and particularly our critical care patients, they can have prioritized sent through the state. And those have actually had turnaround times as quickly as 12 hours from those tests. The process in Ohio, and again, everyone has to actually know their local process for this by knowing what their lab can do and then what their state is offering. But our local process in Ohio is to get approval for the expedited state-based test by speaking with the representatives from the health department of where the person's primary residence is. So in the Southwest Ohio region, we have 5 primary health departments. There are 2 health departments in Hamilton County, which is the county seat for Cincinnati. And then there are 3 health departments in the 3 surrounding counties. So our infection prevention team has had to work very diligently with our critical care teams to know which cases we are suspecting COVID in. And then they have to work with each one of those local health departments to get approval for the expedited state test. And probably from the beginning of the initiation of our concern to receipt of the final test from the state, that's been about as fast as 18 to 24 hours, most recently. I think everybody's beginning to pick up the pace with it a little bit. Early on, as far as who to test, I think this has been actually one of the most challenging questions because of the stakes that exist. We've been taking that quite seriously. We've had a very low threshold for testing locally here. I think really pretty much anybody who had presented in some degree of hypoxemic respiratory failure was having a test initiated by some healthcare provider along their journey to the inpatient hospitalization phase, whether that was an outside hospital emergency department, our own emergency department, the initial admitting person for the intensive care unit, or if they initially went to the hospital service before they got more sick and required intensive care level. And so I think we have embraced a low threshold for sending tests because we didn't have any experience with exactly what this should look like. We've read about it. We know that it's somebody who seems to present with a cough, myalgias, fever, poor appetite, shortness of breath, and an X-ray that likely demonstrates peripheral hazy opacities, and particularly a non-cardiogenic pulmonary edema type pattern. But I think that for a lot of us, we were very cautious to not miss the atypical or mild cases, which may exist in even some of the more critically ill, so as to protect a lot of the healthcare workers from exposure, because we didn't want our system of care to begin to suffer if we developed a cluster outbreak from not putting the proper PPE measures in place. This was and has been balanced against not overusing PPE on patients who ultimately have a low probability of having the coronavirus or patients suffering from COVID-19. So I think to be honest, we're still improving our barometer on who to test. I think again right now I think we are still embracing to have a low threshold for that testing. We have moved towards, because of the core lab testing taking a bit time, is that over the first 24 to 72 hours of the hospitalization, if the patient declared themselves to have an alternative cause of being hypoxemic, short of breath, or having a fever, we have been, based upon provider judgment, begun to de-escalate or even cancel the COVID test once they're several days into their hospitalization, when again it becomes very clear it's another cause, and we're not worried about COVID-19 at all.
Great. So moving on to another question. So how has COVID-19 affected medical care, I guess, for non-coronavirus patients? I can tell you, like many other institutions, we've had to cancel, reschedule elective cases, in some cases indefinitely. What have you guys been doing for like emergent stroke cases or subarachnoid hemorrhage or status epilepticus patients? How has COVID-19 affected your day-to-day operations, and how have you all adapted to this new reality, I guess?
Well, it's part of the cost of a pandemic is not just the patients who suffer from the pandemic virus itself or the pandemic at hand itself, but part of the fallout is that, in my opinion, it makes our routine medical care much more complicated, right? The access to ICU beds or even to outpatient management because of the limitations in social distancing, et cetera, routine follow-up for pulmonary disease that we're managing with immunosuppression or for cancer, nodule monitoring, et cetera, all has been really delayed. And I think in the long run, we're going to observe that as part of the burden of the health impact of this virus. is not just this disease process, but all disease processes.
Moving to a slightly different topic of team reorganization. Neha, you work at Mount Sinai, and like many other New York institutions, you've developed a COVID unit. Can you tell me how you guys restructured your teams, and if you could touch base on any training and drills that you guys have implemented in your institution?
As you can imagine, we had to implement a lot of changes to how we're going to provide care in anticipation of the surge in COVID-19 patients. So one of the first things that was done throughout the health system, elective surgeries had to be cancelled so we could provide more ICU beds. There are some hospitals within our health system where we were able to carve out dedicated COVID units. We started with one dedicated COVID unit, and there were discussions about what thresholds we would use to activate the second, the third, and right now we've activated our third COVID unit. Some of our other hospitals within the health system are already experiencing that the entire unit, despite not necessarily planning to become a COVID unit, has become a COVID unit. So I can speak more to the reorganization of our neurocritical care patient population. So within the health system, we have 2 neuro ICUs. So we moved back to our old unit. Incidentally, in October, we had moved to this brand new 18-bed state-of-the-art ICU, and we graciously left that and went back to our old ICU, which has 16 beds, and we decided to keep our non-COVID positive neurocritical care patients in that unit. In terms of preparing for what's to come and how do you provide safe, effective care, in addition to some traditional, PowerPoints, and I'm sure health systems across the country are doing this, coming up with internal policies, procedures, and learning from each other's experiences, and the influx of phenomenal amount of literature from across the world to guide us in how we can successfully provide care for these patients and how do we flatten the curve. We've, of course, incorporated all of those into our local policies and procedures. Disseminating that information, we've been keeping track of all of these different policies, procedures in shared drive, Dropbox folders, etc. More recently, we started simulations for various things, right from donning, doffing of PPE to proning. How do you manually prone patients? As you can imagine, a lot of our non-critical care colleagues are also being called upon to help us on the front lines. So some of this education material is also directed towards them. And it's been so heartening to see the response from everyone across the board, right, from physician colleagues in different subspecialties to APPs who were involved in, elective surgical procedures, outpatient clinic, etc. So once we stopped doing elective surgeries, outpatient clinics were also closed down. Telehealth, in-person outpatient clinics were closed down, and emphasis on telehealth. So educating the health system on how to leverage some of our telehealth resources to continue to provide continuity of care so that we can keep the rest of our population healthy, and also educate them about the prevention of community spread of COVID. So there's been a lot of reorganization. The leadership has been very proactive, and I think it's been fantastic to see. And of course, it's not like everybody has all the answers, right? From, what's going on with projected PPE shortage to the projected numbers of patients that we're going to see, etc. Of course, everyone's just figuring this out as we go, but knowing that the bottom line is we're all in this together, and that spirit is permeating throughout the health system. So it's been very heartening to see that response.
All right, excellent. So moving on to a rather politically charged topic or question. I guess there's no sugarcoating this question, but who gets the ICU bed and who gets the ventilator? What criteria should we be following under these circumstances while we're almost forced to make a moral pivot in how we are trained and programmed to triage our patients? Where we said we're always trained to say intensive care for all patients who need it. And now we're almost being forced to embrace a completely different mindset, almost a wartime triage mindset, where it becomes necessary to follow distributive justice and the appropriate allocation of limited health resources.
In the Seattle area, we have not yet reached crisis standards of care, but once we do, the statewide triage team has been meeting in preparation for that. And one of the challenges for, comparing standard crisis, if there can be standard, but what we typically lay out as crisis standards of care about evaluation for each patient currently occupying an ICU bed and each patient who might require ICU care, of using a triage team to identify which patients receive that care if it's in limited supply on a daily basis. And those decisions are removed from the bedside here. That's our plan. We have not reached those standards of care, thankfully. But a third-party group that is blinded to demographics, with the exception of age and comorbid disease, will be deciding on a daily basis whether to continue the ICU resource utilization for an individual patient. So each patient will be identified and reviewed on a daily basis. The problem that we see with that is that this disease is once you have onset of ARDS, the time to recovery that we've been observing at this point is quite slow. So when patients recover, it tends to happen over weeks rather than quickly, as we would hope. So we've had to adjust our mindset about the idea that failure to improve is not the same as worsening disease. And so in that concept, it would be patients that are improving or stable would continue to receive care, and patients that are worsening might have their care resources reallocated. The other issue that we've debated about while we're starting to consume a lot of our resources is the observation that the very elderly are extremely unlikely to survive. And we've all struggled as a community as to whether, you can see this pattern developing, that patients that are extremely infirm and susceptible to this disease tend to be, or were at least in our community, the first that showed up and became the majority of our ICU population very quickly. It's hard to go into that, to use up a lot of your resources or to allocate a lot of your resources even before crisis standards to patients that are very unlikely to survive. And I think it's a big change in the mindset in our country. I think other countries are more facile with the idea that maybe you wouldn't put an 88-year-old on the ventilator for ARDS and just wouldn't offer that even at baseline. The change in the U.S., where, as you say, anybody who requires ICU care, it's an option. We've started debating, should we put people on the ventilator when they're in a population that has, less than a 5% likelihood of survival of this disease, not only for offering false hope or prolonging the end of their lives, but also realistically, it's extremely difficult morally and emotionally on the staff to continue day after day to care for patients who are having a 95% chance of not surviving, if not more.
So we similarly we are in the beginning phases of this discussion within our region. We have a health collaborative that is bringing together the different healthcare institutions within our area to define this. I mean, fortunately, I think the one thing I think it's really important for everyone to be aware of, we don't need to create the wheel totally on this. There are resources out there that have outlined this. In New York State, there's actually a pretty impressive, 270-page document that provides some degree of guidance on what to do in crisis situations where the demand exceeds the resources available. There's statements from the Institute of Medicine, from the National Academies of Science. The state of Minnesota has one. Michigan, I think you mentioned that Washington has one. So, to me, these questions, and I think answer this great. They can't be a bedside decision that the clinician makes. We need to begin to really solidify what we think as society says about who should we be allocating the resources to, and make this a social decision. I think we as the medical professionals need to help guide about who is unlikely to benefit or is quote unquote futile in deriving benefit from the resource intensive treatment. And I think that based upon what we believe to be patients who are unlikely to benefit or from treatment, that we provide objective, measurable, validated things across different people that say that these are the people who are unlikely to benefit. And that way it becomes objectified, identifiable, and we can educate the public on this. I think engaging the public on this is critical. I think for me, I see a lot of parallels between this and EFIC-based research, where if we're going to do research that's an exception from informed consent and we take away informed consent from patients in order to perform these things, as we know there's a huge community consultative component of that. And I think as we derive these things within our states and our regions and or explore what our states have already drafted, that we need to make sure that really the community is involved and embraces whatever we as a medical community are suggesting as far as these what level of resource utilization triggers it, and then which patients then would then begin to not qualify for those resource intensive therapies. I also think it's really important as we have these conversations going forward within our states and our regions, we don't think of this as which COVID patients qualify for treatment. I think it's important for us to think about which critically ill patients would qualify for treatment. So it's not just a COVID question. I think this is a critical care question as well. I think the COVID question is difficult because we're really beginning to learn about who responds to the treatment and in what time frame, and what does the long-term outcome look like for these folks. And I think that we're probably going to have to really be quite agile and flexible with which COVID patients we would consider to provide the resource-intensive therapies as we begin to understand a little better what the 2, 4, 12-week outcomes look like in COVID patients who have received resource-intensive therapies.
Wow. Yeah. No, it's surreal to say the least. So let's dive right into the critical care management of COVID-19. Can we talk a little bit about PPEs, your intubation procedures, and thoughts regarding non-invasive respiratory support such as high-flow nasal cannula, BiPAP, and CPAP?
We have had robust debates in our system because, as you can imagine, we're continuing to work to balance safety of the staff and support of the patients. So we have tended toward early intubation for these patients for two reasons. One is that we have seen that once they're starting to require more supplemental oxygen, that many of them quickly do deteriorate into profound ARDS quickly. So none of us wants to rush into intubation situations where we feel like we're donning PPE in a rushed way, and that intubations we'd like to have in a controlled setting. And we also are concerned about the risk of aerosol generating procedures. So intubation is obviously a high risk one, and we're all using PAPRs in those circumstances when we're doing it, and actually tending to use glide scopes or video laryngoscopy as opposed to direct laryngoscopy. We've limited the amount of flow on the high-flow nasal cannulas that we're providing. For some patients, we have been able to support them with somewhat limited amounts of liter flow of supplemental oxygen, but have set sort of an upper limit in terms of what we're doing, not only for the risk of generating aerosols, but also, again, identifying patients who would require intubation and wanting to do that in the controlled setting. We have pretty significantly limited the use of non-invasive ventilation for these folks. We don't have the helmet bubble style that you're seeing in the video, in videos from Italy, et cetera, which seem like they would actually be pretty good at controlling the amount of aerosol because there's a dedicated expiratory loop that you can keep a HEPA filter on. So we've been really limiting the use of BiPAP for patients that have suspected or proven COVID to limit the amount of aerosol generating procedure.
What upper limit of nasal cannula flow have you guys have defined in your institution?
So we're limiting the flow rate to, and it changes constantly. So because there's not great data on it. So right now we're limiting to 30 liters per minute as our maximum for high flow nasal cannula and up to 50% supplemental oxygen. For many patients, if the benefit that they're receiving is some amount of positive end expiratory pressure, we can support them reasonably with that. But that's the limit that we're currently using in our system. There are other communities that have not limited the use of either BiPAP or high flow.
Those limits are before you'll intubate or before you consider it to be aerosol generating and requiring airborne precautions?
So, any of those patients are on airborne precautions if we're using anything so both the high flow patients and BiPAP patients are always on airborne precautions. But when we get to the higher levels of flow rates, we have a serious discussion about going forward with intubation.
All right. Regarding other supportive care, are any of you providing any virus-directed therapies such as chloroquine or hydroxychloroquine, azithromycin, remdesivir? And what are your thoughts regarding ascorbic acid's role for immunomodulator therapy and antibacterial therapies?
It's been very interesting to watch because the data that we have about any one of these interventions is not nearly as robust as what we are accustomed. And, largely, as all of you know, is based largely on case reports of the preceding outbreak area. We're enrolling for remdesivir until recently. I'm not sure if Gilead has completed their enrollment. We haven't been able to get remdesivir in the last couple of patients. We have started using hydroxychloroquine and are debating amongst ourselves as to whether we're going to be adding azithromycin. There is interest in the use of vitamin C, and so actually for all of our ALI or ARDS patients, we're starting vitamin C so long as they don't have a history of calcium oxalate stones or issues requiring very frequent glucose monitoring, like hourly glucose monitoring with the issues of Accu-Check at the bedside. And we started actually considering the use of tocilizumab or other IL-6 inhibitors in patients that have features of a hyperinflammatory state, and are doing our best to gather robust clinical data about those patients to try to figure out which interventions are the most helpful.
Perfect. So what are some of the COVID-19 neurologic complications that you guys have witnessed or can talk to us about?
Based on some of the retrospective data, I'm sure everyone's seen that the risk of cerebrovascular, new onset cardiovascular diseases could be as high as about 9% in these patients. We haven't directly seen that yet, but because of all the microthrombi that these patients could form, a DIC state that these patients could come in, we know that these patients are at a higher risk. What was a little interesting to read was for these patients, about anywhere between 20 to 30% patients could potentially not have a good outcome, but that's a very small experience. I think it's very important to track neurological outcomes closely as a neurocritical care community. And some of our neurointensivists across the country have been talking about starting a database and all participating in a multi-center, just prospective longitudinal cohort study to understand the neurological effects of COVID-19 better. Also, simultaneously, there have been discussions amongst our citywide neurointensivists to figure out what we're going to do with that burden of cerebrovascular disease that we might end up seeing in COVID-19 patients. How do we modify our triage and transfer protocols? For Mount Sinai Health System, for the neuroemergencies management and transfers program that I lead, we perform over 1,000 neuroemergency transfers, and that we really had to modify to, right now we're just doing life rescues. We're doing a fair amount of treat in place, but I haven't experienced a surge in COVID-19 positive cerebrovascular diseases just yet.
Right. When should one consider proning in COVID-19 patients?
I think the Chinese data used proning very aggressively once the PF ratio was less than 150. We've seen in our patients that they are significantly improved with prone positioning. So frequently that's the most effective rescue for hypoxemia. And so I would encourage people to use that early for both the fact that it's very effective, but also, as these patient populations grow, other rescue strategies like the use of paralytic agents can become scarce resources, and then the use of nebulized ibuprostanol, does confer some risk to the respiratory therapists who have to be in the room quite often for running that medication. We are also using manual proning, as Neha mentioned, and so we do it pretty early.
Great. One final question. What are some of the potential pitfalls in the management of COVID-19 that you can talk to us about?
One that I would like to point out, in our first observations, we have a text chain among all the intensivists in the city, and that's actually been a great resource for us and for real-time information to share with each other about resources and also any pointers about management. One thing that one of the hospital systems noticed is a high number of what appeared to be a cardiomyopathy, abrupt cardiomyopathy, and then leading to bradycardia and asystole. And we've been having a debate here about whether that actually represented a direct myocardial injury from the virus itself, or whether there is an increased risk of propofol infusion syndrome for these patients. The things that they had noticed were that there was a rise in CK, not with an associated rise in troponin. EF would drop to about 10% or less, and were responsive to dobutamine, but not necessarily with a low mixed venous O2 sat. So it seems like it may be that they're more susceptible to propofol infusion syndrome. We're all sort of, as I mentioned, still debating that at this time.
In Cincinnati, we are certainly just beginning with this. I'm actually, we have moved towards placing we actually place introducers in our COVID positive patients who are on a mechanical ventilator to be prepared to actually be able to float a transvenous pacer to help support them through this with the idea if there is indeed just a viral myocarditis or cardiomyopathy that's developing in these patients. It's all based upon our understanding that the angiotensin converting enzyme receptor is in the lung, heart, and GI tract, which is where the symptoms are. So given the observations in the Pacific Northwest that a lot of these patients weren't dying from hypoxemic respiratory failure, but from cardiovascular complications like arrhythmias, we have moved towards putting more monitoring in place to be able to begin to observe this. So we've been placing our patients on blow track and placing an introducer for our central access for these patients to be able to handle the complicating cardiovascular complications in these patients. I don't know if it's going to help, but that's what we're doing for now.
One big change that we made to our practice, we are practicing critical care like we were doing, a little over a decade ago with the whole humanized CICU movement.
All right. Well, thank you guys so much for taking time out of your busy schedules to help us record this special edition on COVID-19. To the audience, thank you all for listening to this episode and stay safe. This is your host, Fawaz Al-Mufti.
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Lamani Ballou, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Stern-Nezer, and Chris Zamet. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcasts. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.